Now we had seen about the various forms of cell death. Now let's move on to the intracellular accumulations. So intracellular accumulations can either be pigments, lipids, glucose or protons. So under pigments we have melanin, hemosiderin, lipofuscin, copper, homogenesic acid and carbon. Under lipids we have triglycerides and cholesterol accumulation. In glucose we have glycogen storage diseases and diabetes in which there is going to be glycogen deposition. In proteins we have various protein deposits, namely Mallory-Hyland bodies, then Russell or Dutchell bodies, then misfolded protein accumulations and neurofibrillary tangles. So let's see one by one. So under pigments, the first pigment will be carbon. So carbon is the most common exogenous pigment which comes from the vehicle dust also, right? So it is a black color pigment. So during inspiration, it is entering into the lung and will deposit in the lung. So in the lungs, this alveolar macrophages will take up this carbon particles and it will be laden, this macrophage itself will be laden with this carbon laden particles. So this is the image of a anthracotic lung. So this black lung is simply called as anthracosis and it is one of the forms of pneumoconiosis. So you can see it in coal workers pneumoconiosis. The next pigment will be melanin. So melanin is an endogenous black pigment. So melanin is the responsible for our skin color. We all know that, right? So melanin is going to be produced by melanocytes which are going to be present in the basal layer of the skin. So melanin can be stained with the help of Fontana-Mason stain in which it is going to stain black. So the special stains are always important. So Fontana-Mason stain and Schmall stain are going to stain melanin. So in Fontana-Mason stain, melanin will be stained black, while in Schmall stain, it is going to be stained emerald green. Then what are the pathological conditions wherein you see melanin deposition? One thing will be malignant melanoma. So it itself is a tumor of melanocytes. So melanoma cells can contain this melanin pigment. Other than that, in a Parkinson's patients, you have a deficiency of dopaminergic neurons that we all know, right? So in dopaminergic neurons are normally present in the basal ganglia, especially in the substantia nigra. So dopaminergic neurons usually contain pigment called as neuromelanin. So this substantia nigra area is usually black in color. So this is the normal substantia nigra basal ganglia area. It is appearing black in color due to the presence of neuromelanin. But in Parkinson's disease, there is going to be loss of this dopaminergic neurons, which will result in the pallor of this substantia nigra. Okay, so in Parkinson's disease, we see the characteristic inclusion called as Lewy body, which is composed of alpha synuclein. So this is the Lewy body here. There is going to be a darker center surrounding which there is a halo. So this is the characteristic appearance of a Lewy body, and this darker pigment which we see, no, dot dark pigment. So that is nothing but the neuromelanin. And in Parkinson's disease, we have seen about melanin's involvement, right? Other than that, there is a hemochromatosis. So hemochromatosis is an inherited iron excess overload disease. So it is an autosomal recessive disease which involves the skin, liver and pancreas. In liver, it is going to cause cirrhosis, and in pancreas, it is going to cause diabetes mellitus, and in skin, it is going to cause a slate gray kind of a pigmentation. So this pigmentation is usually because of hemosiderin, but mostly it is because of melanin. So melanin more than hemosiderin is the cause for the slate gray pigmentation which we see in hemochromatosis. And this pigmentation in this hemochromatosis is usually called as bronze diabetes, since it is associated with diabetes mellitus. Then we'll see about the third pigment, which is homogenesic acid. It is also a black pigment only, seen in conditions called as alkaptonuria. So alkaptonuria is an autosomal recessive condition due to an enzyme deficiency, which is homogentisate oxygenase. So homogentisate oxygenase deficiency will result in alkaptonuria. So there is going to be deposition of a black pigment in various connective tissue, and that is going to be called as ochronosis. So in cartilaginous tissue like the ear lobules and also in the sclera of the eye, you can see blackish deposition in these patients, and that is called as ochronosis. And the classical history will be urine on standing will become black. Okay, suppose the kid is wearing a diaper. So once the urine has passed, so after some time the diaper will change black in color due to oxidation. So normally when the urine is passed, it is going to be yellow in color, but after some time if you let it be like that, it is going to turn black in color. Then now the next pigment will be lipofuscin. So as the name suggests, lipo means lipid, fusion means fuscus. Fuscus means brown color. Okay, So it is going to be a brown colored pigment. It is also called as lipochrome or a wear and tear pigment. Wear and tear pigment which can be present in senile atrophy or brown atrophy. It's also called as senile atrophy or brown atrophy. So why it is called as a wear and tear pigment? Because it is formed as a result of lipid peroxidation. So free radical injury led to lipid peroxidation in the membrane, right? So this lipid peroxidation from the phospholipids derived from the membrane only, these lipofuscin pigments are being formed. So the increased number of lipofuscin is actually a telltale injury of the free radical injury, okay? And this lipofuscin is usually seen with elderly age group and also in severe malnutrition and cancer cachexia. So they have a characteristic location in the cell. It is going to be a perinuclear pigment. So perinuclear yellow-brown finely granular pigment, if they mention in the history, they are mentioning about lipofuscin. So this is a cardiac myocytes. So can you see this connections between the cardiac myocytes? So in the perinuclear location, you see this yellow-brown kind of granular pigment, and this is nothing but lipochrome or lipofuscin, which is as a result of lipid peroxidation as a result of free radical injury. So electron microscopically also, this is the nucleus of the cell. So around the nucleus, you see this electron dense pigmentation. So this is nothing. So around the nucleus also, you see this electron dense pigments which are seen. So these are nothing but the perinuclear pigment, which is lipofuscin. So the next pigment will be hemosiderin. So hemosiderin is actually a pigment of iron. So you see it in conditions of iron excess or hemorrhage. So whenever there is iron excess, suppose it is an inherited condition like in a hemochromatosis. So inherited iron excess will be seen in hemochromatosis, which is a autosomal recessive condition again. Other than that, when there is a hemorrhagic condition, so suppose you get a contusion. So contusion is with the blunt trauma, you all develop this black colored pigment, right? So that is nothing but hemosiderin deposition only. So the RBCs will be broken down by the blunt trauma. So these RBCs which are being lysed, it will be taken up by the macrophages, and then it will be converted into this hemosiderin. So this hemosiderin pigment is going to be deposited in these conditions called as iron excess. So hemochromatosis, I already mentioned, it is a triad of syndrome which is going to involve the liver, pancreas and the skin. So in the liver, if you see, it is going to be a golden yellow pigment which is refractile. Okay, refractile in the sense it will change planes. So hemosiderin is a golden yellow pigment which is finely granular again, and it is seen as a refractile pigment in the liver. Since it is containing iron, it is going to be positive for Pearl's Prussian blue. So wherever iron is present, you can always stain it with Pearl's Prussian blue. So the next pigment will be copper pigment. So copper is going to be a brown colored pigment, and it is going to be accumulated in a condition called as Wilson's disease. So Wilson's disease is again an autosomal recessive condition due to a ATP7B defect in chromosome 13q. So in this, there is going to be copper excretion into the bile, which is going to be defective. So when copper excretion is defective, copper will start accumulating in the hepatocytes, and that will cause damage to the liver. So here again we can get triad of symptoms involving the liver. So in the liver you can get various presentations like hepatitis and cirrhosis and even fulminant hepatitis. And in the eyes, this copper is going to deposit in the Descemet's membrane of the cornea, which is called as Kaiser-Fleischer ring. Cornea Descemet's membrane is going to deposit. It's called as KF ring or Kaiser-Fleischer ring. So you can see it on slit lamp examination as a greenish brown deposit. And then in the brain, it is going to deposit in the basal ganglia region, especially in the putamen, causing atrophy and cavitation of the putamen. So how do you stain for this copper? Copper is, the special stains for copper is going to be rhodanine stain and rubianic acid stain, which is going to stain it brown in color. Okay, so this is the image of copper deposition in the liver, which is stained by this rhodanine or rubianic acid in a Wilson's disease. So don't confuse it with Orcine stain. Orcine stain is a stain which is going to stain the copper associated protein, which is ceruloplasmin, and not copper. Okay, Orcine stain is not for copper, it is for ceruloplasmin. Other than that, Orcine stain will also stain the hepatitis B antigen, which is HBsAg, and also elastin. So now we had seen about the various pigments. So in lipid, next we'll move on to lipid deposition. So under lipids, we have triglyceride and cholesterol deposition. So in triglycerides, the deposition can be seen most commonly in the liver and the heart. So in liver, it is going to be called as steatosis. So steatosis is nothing but deposition of triglycerides in the liver. It can be either a microvesicular steatosis or a macrovesicular steatosis. Microvesicular steatosis is the one in which there will be multiple small vacuoles of triglyceride in the cell, while macrovesicular will be a single big lipid vacuole which is going to push the nucleus to the periphery. Okay, so this is a macrovesicular steatosis. In heart also, there can be this triglyceride deposition which is called as fatty heart, and usually it gives a appearance of a tabby cat. So one part the normal area will be there, the next you will see the lipid deposition, then again it will be normal. So this kind of alternating pattern of normal and lipid deposition will be there, which is called as a tabby cat appearance. So the special stains used for lipid will be oil redo, as the name suggests, it is going to stain the lipid red in color. And then Sudan black B can also be used, as the name suggests. Here again, the lipid is going to be stained black in color. So both fat is usually processed during the fixation. So fat will be lost during this normal HND staining, routine staining. So it will appear empty on HND sections. So in order to stain for fat, you will have to take a frozen section. So fresh frozen section, if you take, you can use these oil redo and Sudan black B stains to stain for lipids. So other examples in which cholesterol is being deposited in the body is in atherosclerosis. So in the walls of the vessel, you can see this atherosclerotic plaque, right? So this plaque is going to consist of this cholesterol-laden macrophages. Then xanthomas. Xanthomas, again, in elderly people, you can see they'll have this yellow colored plaques which are seen underneath the eyebrows. So these are xanthomas. So on microscopy, if you see in xanthomas, there is going to be presence of dermal macrophages which are filled up with this cholesterol. Then cholesterolosis. So cholesterolosis is going to be a condition seen in gallbladder. So in gallbladder, in the lamina propria, if you see this, it is filled up with cholesterol-laden macrophages again. So this kind of gallbladder is called as strawberry gallbladder, because grossly if you see the gallbladder, it is going to appear like a strawberry. The red part of the strawberry is going to be compared with the mucosa of the gallbladder, while the dark spots in the strawberry is going to be compared with the yellow spots which we see in cholesterolosis. So now lipid deposition is done. Now let's see about glycogen or glucose deposition. So glycogen excess can be seen in glycogen storage disorders, and other than that, you can also see in diabetes mellitus. So in diabetes mellitus, this glucose is going to be deposited in the subnuclear vacuoles. So in the proximal convoluted tubules, if you see, there is going to be the presence of the subnuclear vacuoles which are filled up with this glycogen, and this lesion is given a name called as Armani-Epstein lesion, seen in diabetes mellitus. So what is the special stain used for glycogen? So the special stain used for glycogen will be a periodic acid Schiff stain. So periodic acid Schiff stain is going to give a magenta pink color to the glycogen. And if you use a diastase enzyme along with that, glycogen will be lost. So glycogen is called as PAS positive and diastase sensitive. Why do you use that diastase? Is because there are many things which will be stained by PAS. So like fungal organisms, this glycogen is also stained, basement membrane is stained, mucins are stained. So there are lots of positivity for PAS stain. So in order to distinguish between the other positivity and glycogen positivity, we will have to use the enzyme diastase. So with diastase, glycogen is going to be lost only in glycogen. Okay, so rest all mucin, basement membrane and fungal organism, these are all going to be diastase resistant. Okay, so diastase is an enzyme, we can see it in the saliva. So we use the saliva during this staining process. Last intracellular accumulation will be proteins. So proteins can either be normal proteins which are going to be produced in excess and they can be accumulated, or they could be abnormal proteins which are being accumulated, or it could be some misfolded proteins which are going to be accumulated. So the first accumulated protein will be a Mallory-Denk body. So Mallory-Denk bodies are also called as Mallory hyaline or alcoholic hyaline. So This, as the name suggests, it is going to be seen most commonly in alcoholic liver disease, but it is not specific for alcoholic liver disease because it is seen in other conditions of liver diseases as well. But the maximum number is going to be seen in alcoholic liver disease. So it is nothing but an intermediate filament basically composed of cytokeratin 8 and 18. So it's a very important question. So it deposits as this pinkish eosinophilic material inside the cytoplasm of the cell. So this was asked as an image based question also before, and they asked for the composition of this Mallory-Hyland body. So the next intracellular protein accumulation will be a neurofibrillary tangle. So neurofibrillary tangle is going to be composed of another intermediate filament called as neurofilament plus a tau protein. So this is again an intermediate filament, and this neurofibrillary tangles are seen in Alzheimer's disease. These are characteristically seen in Alzheimer's disease. So these are nothing but the cells are having a flame shaped appearance, and they are composed of this neurofilament and tau proteins. Then we'll see about misfolded proteins. So misfolded proteins, we have two examples. I already mentioned prions disease and alpha-1 antitrypsin deficiency. So prions disease is going to be a neurodegenerative disorder which is highly transmissible also. So the classical image you see in a prions disease will be spongiform neurons. So spongiform neurons are nothing but the neurons are forming lots of vacuolations like a grape. So multiple vacuolations, grape-like clusters of vacuoles are formed, and that is termed as spongiform neurons, which is seen in prions disease. And one thing is, one of the prions disease is fatal familial insomnia, and in this fatal familial insomnia, the spongiform neurons will not be present. Okay. Then in alpha-1 antitrypsin deficiency, this alpha-1 antitrypsin is going to be a protease inhibitor enzyme. So when this a deficiency of this enzyme is present, the protease activity will be uncontrolled, which will lead to damage. So it is going to lead to pan-acinar emphysema in the lung. And in the liver, again, it is going to cause a liver disease leading to cirrhosis. So in liver, if you see, it is going to produce these eosinophilic globules. So this is the normal hepatocyte we see here. But here, if you see, there is going to be lots of eosinophilic globules which are composed of this alpha-1 antitrypsin. And it is going to be positive for PAS again. Okay. So these are misfolded proteins. Then we have Russell's and Dutcher bodies. So these bodies are these are basically intracellular accumulations of immunoglobulins we see in the multiple myeloma disease. So multiple myeloma, we all know it is a plasma cell dyscrasia. So in these plasma cell dyscrasias, there is going to be abnormal immunoglobulin produced, and these are going to accumulate inside the cell. So Russell bodies are nothing but intracytoplasmic immunoglobulin accumulations. So it is going to be intracytoplasmic. So when there are lots of Russell bodies seen in the inside the cytoplasm, it is going to appear like a grape. So the cell itself is composed fully of this Russell bodies, and it is appearing like a bunch of grapes. So this cell is called as a Mott cell. And then we have Dutcher bodies, which are intranuclear immunoglobulin depositions. So inside the nucleus, you are seeing lots of these inclusions, right? So all of these are Dutcher bodies seen in multiple myeloma.